Morning everybody, thank you for joining us on our fourth One Medical Group breakfast webinar. This is our fourth in the series, so we're delighted to be back. As always, I'm joined by an expert panel who are going to talk us through and debate today's hot topic. The aim of our webinars is to provide you with some practical tools and tips that you can take back and share with your practice teams or within your primary care networks. And as always, if you'd like to get in touch with us after the webinar or you'd like to speak to any of our panelists, you can email us at webinars@onemedicalgroup.co.uk. You'll all receive emails from Holly, who's our events coordinator for the webinar series, so you can get in contact with Holly directly as well. I'll introduce you to our panel today. So we have Rachel Beverley-Stevenson, who is the Executive Chair and the co-founder of One Medical Group. We have Paul Wainwright, who is a Director at QAD Architects, and we have Paula Mace, who is Head of Healthcare at Aitchison Rafferty Consultants. I'm going to let our panel introduce themselves and tell you a little bit about their careers and their roles. So panelists, you've got 30 seconds each. Rachel, we'll come to you first.
Thanks, Caroline. Good morning, everybody. I'm Rachel Beverley-Stevenson, and as Caroline has said, I'm one of the co-founders and executive chair of One Medical Group, and we're a healthcare company working within and alongside the NHS. We started in primary care property and healthcare property, and then moved into care delivery, and now have divisions that also support that delivery in technology, wellness and workforce. So we have a broad knowledge and a broad experience base that we can draw on to help primary care providers, networks and other health providers tackle some of the challenges, including estates that we're going to talk about today, but some of the other challenges that are facing us as we move into our brave new world.
Brilliant, thanks Rachel. Paul, tell us a little bit about you and QAD.
Okay, hello and good morning everyone. I'm Paul Wainwright, one of the founding directors at QAD Architects. We are based in Leeds but operate nationwide. Our architectural studio specialises in a number of sectors, with primary care being one in which we've developed many extensions, refurbishments and new build projects over the past 15 years. And I head the healthcare portfolio of work for our practice.
Thanks, Paul. And last but not least, Paula.
Good morning. I'm Director and Head of Healthcare at Aitchison Rafferty, where I've worked in the healthcare department for just under 18 years now. We specialise in all things GP premises, from valuations, notional rents, landlord and tenant issues, grant funding extensions, anything you can think of really. And we've had a long-standing relationship with One Medical, both myself and my predecessors for many years.
A long time.
That's great, thank you panel. Which neatly brings us on to today's topic, which is maximising the potential of our buildings across primary care. So just to set the scene, obviously we're all aware it's a challenging time for primary care. And we're yet to truly understand the impact of our two waves now of COVID and how that's impacted primary care. What we do know is that the evolution of PCNs is happening a lot quicker than the policy development from the centre. And so we know that PCNs are evolving in terms of our patient population and the way that we deliver services for them. The number of services that PCNs are having to deliver as part of the DES is evolving and is growing. And most recently, obviously this week, we now see that PCNs will be the main body through which the COVID vaccination will be rolled out nationwide. And then we see the workforce of PCNs growing. So we know that by FY 23-24, the average PCN will have taken on an additional 21 staff working as part of their network. And the biggest question is, where do we put them? We know that PCNs are concerned that as they grow and they bring more staff and they expand their MDT across their PCN, where we place those individuals is really important, both to meet the needs of our patients, but also in terms of service delivery and logistics, where they sit. There are already some really good examples out there of neighbourhoods working collaboratively to try and solve the estates problem. So the Orford Jubilee neighbourhood in Warrington have a community hub where they've brought together leisure, education and healthcare all under one roof. And there's lots more examples. Many of you will know of Bromley by Bow and their centre, in which they've really adopted kind of an integrated community model. But it's also important to recognise that the funding for new builds isn't always out there. So we have to maximise the most that we can from our existing estates. So I'm hoping our panel today are going to come at this from different angles, give you some advice and guidance on how to maximise your existing portfolio, how to work with your community partners, but also if a new build or a sale and lease back is an option to help you as part of that programme, where you can go to access that support and advice. So we'll turn to our panel. So Rachel, why should PCNs be considering an estate strategy as part of their forward plan?
So you touched on some of the points there, Caroline, around an emerging new widening workforce and practical points around where they will be. But I think there's another point, which is PCNs are, although we're 2 years into this, they are still emerging organisations getting used to working with each other. So the first thing is understanding what you've got collectively as a primary care network. What kind of estate do you have access to? Both in forms of you may own it or you may be able to access it on other sessional terms. So what do you have as a collective primary care network? How is it working? And we'll talk more about that as the other questions come throughout the session. But how do you use it? And you know, what else could you be doing with that estate to help deliver the care that you need for your combined population? Because we say, as a provider and property specialist, that the care environment and the estates from which you deliver it should be seen as part of your care team. It is core to how those models of care are then delivered to patients. So understanding what you've got, where it is, really practical things that I'm sure Paula and Paul will touch more on as we go through the session, but things around lease arrangements, who owns what, service charges. There are benefits that can come from primary care networks working together on things like facilities management, contracts, you know, sharing the load literally and sharing the costs. So there's lots of practical bits that we'll no doubt unpick as we come through the questions.
Brilliant, thanks Rachel. Paul, do you encourage primary care networks to think about estates as part of a forward plan?
Yeah, well, as architects, naturally, yes. I think fundamental to forward planning is how are the services going to be delivered, and key to that is the physical environment, which can either assist or hinder depending upon if those spaces have been properly analysed at that high level. So the physical environment can't be ignored, or I'd say ignore it at your peril, really. All too often, we've seen facilities that are the result of no strategic planning, but a series almost of reactions to piecemeal crises and or funding opportunities. This then results in disjointed, uncohesive and often jumbled and inefficient layouts. And these are often confusing for patients to navigate and inefficient to run and operate. So what I'm not saying is that you need to come up with a plan and then implement it in its entirety from day one. But what is likely, you need to look at what, you know, it's going to be unaffordable to do that. But by having that overarching plan, you can then work towards an end goal. If there is a framework as to where and in which direction a strategic plan is headed, this can be enacted and evolved over a period of time without decisions taken today, potentially precluding opportunities in the future, because we are then operating within an overall strategic framework. The initial high-level strategic question might interrogate which services should be located in which building, which site, more than one site, that kind of thing.
Brilliant, thanks Paul. And Paula, you work with practices and PCNs across the country, similar to what we do at One Medical Group. So do you encourage practices and then working up towards PCNs to think about a strategic plan for their estates?
That's right, absolutely. And as Paul says, a plan can't be implemented straight away. But when you look at your property, that's is going to be your most significant asset, or most likely in terms of cost or long-term commitment. So really it is important, very important, to have an estates plan and try and get it right. You know, we do recognise, everyone recognises that at the moment we are only working with what we've got, but the key thing is to look at where you want the services, what the patient needs are, and the location in which the services need to be provided, what you've already got, how this can be adapted, and what you need, so that you sort of avoid a rush investment, or, you know, redesign or reconfiguration that actually hasn't been well thought out. So a plan, you know, it may take several years, and there's no doubt that you know, at the moment we can only work with what we've got. But you know, there's also considering what other local spaces available. It might not necessarily be the need of having something new. You might be sort of subletting some local office space that's been, particularly in COVID times, there's lots of vacant space for staff that don't need to be on site. So it doesn't necessarily just mean rebuilding or getting a new building, but a plan is very important to make sure you're spending your money correctly over a period of time.
Thanks, Paul. And we'll come on to the COVID point in a moment, because I know we've got a question about that. So, no, we'll neatly come on to that shortly. So moving on to our second question, we know it's no secret that the ARRS funding available to PCNs means that the workforce is going to significantly grow over the next 4 years. And the biggest question that we're being asked by PCNs is, where do they put this growing workforce? So I know our panel have got different views on this. Rachel, I know you're particularly passionate about making sure PCNs are bringing in the right workforce, first of all, and then thinking a little bit more creatively about where they put them. So I'll turn to you in terms of what advice would you give a PCN in terms of where they put these new staff?
So thanks, Caroline. The first thing I would say is a bit like I said for the first question, is understanding what you've got. So by that I mean, who are your patients collectively that you are serving? What are the needs? And if you can, access some data modelling to help you understand how patients access the services currently, where there are gaps, where therefore you should be filling with different skill sets. You may think you need a pharmacist and a physio, but actually if you look at the patient demographic and the need across your whole primary care network, it may be a bit more pharmacist, a bit less physio, it may be a PT to do some work around frailty and pre-frailty, mobility, that kind of thing. It's understand the need first, and then you can craft your workforce around that. Then you can look at, right, where are they best placed to be looking after these patients? And as Paula said earlier, there is other space that can be accessed. So if we've done the first step, which is understanding what we've got collectively as our group estate within our primary care network, then we've looked at our modelling, then we can look at, right, where are the gaps? Where do people go to receive care? And if we're wanting people to really engage with a new way of delivering care, there's a practical thing that people are very busy, even in lockdown, and very stressed and very anxious. So what we want to do is make the interventions as easy to happen as possible, and not to make it an additional thing for people to have to do. So if you can find places, it might be your doctor's surgery for already going in there, but maybe a local high street where there is lots of space, or an office block, as Paula said, where you can have incidental exposure. So you're just giving them the support they need at a time that is not interrupting their life. And then that way they're more likely to engage, and it may then drive you to think, okay, we don't need lots more consulting rooms. What we need is a few more, but a bit more flexible space that we can hire sessionally. I'm sure we'll expand on that.
Thank you. And just for the benefit of all our delegates that are watching live, if Rachel or any of our panelists say something and you don't understand, or you'd like to ask a question in relating to that, please do feel free to use the questions box that you'll find on your toolbar. And if we can't answer your question during the webinar, we'll get in contact with you afterwards, certainly, and put the panelists in contact with you. Rachel, I know when we spoke previously around PCN estates planning, we've talked around space utilisation.
Yeah.
Do you want to expand a little bit more?
Yeah, so that sounds quite an obvious thing, doesn't it? So understanding how your building is currently used. I mean, we all recognise the conversations we'll have with practices within our own organisations. I haven't got any room, we can't fit any more people in. But actually, if you look at, and that might be right, but if you do an exercise, it's a very simple exercise. It's really just timetabling, looking at all the rooms you've got, how they are used, who uses them when, then that will tell you whether there is any spare space, or if the space could be used differently. And you may have one site within your network that has more space than another, and then that plays back to the where do you put the people and the people that you're bringing in. The other point that I didn't mention was it's not just the workforce that you're bringing in, it's the administration and looking after them that you need to think of as well. And I know that we're talking to networks at the moment that are increasing their administrative teams to look after the new workforce that's coming in. So it's not just about the workforce, it's then about how do you look after them. Do you centralise some of that administration, and then do you move that to one site and others to another? But coming back to your question, Caroline, if you do that piece of work around space utilisation, which is an addition really to the looking at what estate you've got, then that will give you an idea of where the need is, where the pressure points are, and what can be tweaked. But there are people who can do this for you. That sounds like quite a big piece of work to do, and it can be, but there are organisations such as ourselves and others are available who can help with that kind of work.
That's great, thanks Rachel. And I guess that leads neatly on to Paul. So from an architect's perspective, Paul, I know you've been doing some really exciting stuff around helping practices or designing new builds that are designed with kind of this new way of working in mind. So as Rachel was saying, you know, there is something around understanding the physical space. And also we're seeing practices are growing in terms of the digital offer that they're providing for patients. So things like digital triage suites and reconfiguring existing space is really important. So I'm going to turn to you and your expertise in terms of where do we put this growing workforce and how can we work creatively with our buildings?
Well, I think building on what's already been said, that the first thing crucially to look at is it's not necessarily about the creation of new space. It's about optimizing space that we've already got in the first instance, either as in its existing form or as an evolved form as well. So it might be that with slight interventions into that existing space, we can make it work better for us, and we can give ourselves more flexibility. So it's not necessarily about the creation of new space. Often it may be about space work better or more efficiently is a key thing that I'd really like to stress. We do, however, need to keep in mind the quality of the environment and places that are being developed. It's not all about just the physical dimensions of spaces. Considerations that are often overlooked, for example, as well, are partner organisations. Paul has touched on looking beyond the immediately obvious as well, or space in the community. What might others have that's available that is currently being underutilised? Local community centres, sports centres, church halls, schools, for example, that kind of thing. All of that needs to be looked at, I'd stress quite strongly, before necessarily looking at creating this new thing that you might have to do within the existing primary care network. I kind of went off topic a little bit there, but hopefully that gives a flavour.
Don't worry, Paul. No, that's fine. And you know that links back to, there's a document that we're going to send everyone that's watching out afterwards, which was published by the Greater Manchester Public Health Network back in 2016, and that looked at how to develop that community asset mapping. So as Rachel says, you know, instead of trying to change the way you deliver care or trying to drive people's behaviours to access a service, take the service to where people are already going. And there are some fantastic case studies in this document. I mean, it was published back in 2016. You would like to hope that we've moved on a lot since then, but a lot of the case studies are actually still really, really relevant. So we'll share that with everyone that's watching afterwards. It gives you a nice step-by-step process as well as to how to approach some of that community asset mapping to maximise that space. Thanks, Paul. Paul, I'm going to come to you next. So in terms of where practices creatively work together to put all these additional staff, I imagine you and your team are touring the country a lot, visiting lots of different practices. So what golden nuggets can you share with us?
That's right. Well, we see a huge variety of different premises, from, you know, an area that has perhaps lots of small converted premises that are really not fit for purpose anymore, you know, and other, you know, large substantial medical centres that can probably quite easily be adapted in many ways. And there's already a huge pressure on GP practices before all this came along, you know, to get the primary care networks in place in a short period of time, as well as the additional pressures we've got at the moment. And you know, what the many premises will also be concerned about is CQC requirements. If we're sort of squeezing a lot more people into a much smaller space, you know, are we going to be causing more problems from that point of view? You know, and it does go back to having an estates plan. There's no doubt that at the moment we've got to manage with what we've got, but we really do need to be looking at where the service is required and how we can fulfill those needs, making the most of digital consultations and various other aspects where possible, and space sharing. You know, somebody uses it in the morning, somebody uses it in the afternoon, but there's also the doctors and, you know, their healthcare professionals are going to be concerned because guidance is going to become ever more demanding, ever tighter. It is already. Requirements only going to become more and more, which essentially will incur more costs to them. So it's going to put a lot of pressure on people. So it is all about forward planning, and for the time being, really thinking hard about what you've got and where, and making the most of that and building on that.
Thanks, Paula. And I guess that neatly then links back into Rachel's earlier comments around space utilisation and understanding how you're currently working with what you've got available, and then developing a forward plan, you know, off the back of that to say, okay, well, where do we envisage our services are going to be in 5 years' time? What do we envisage the needs of our patient population are going to be? And then how do we use what we've got to match that? We've had a question come through from one of our delegates watching, which kind of neatly knits into our last question, really, which was around what support is available to primary care networks in terms of guidance, advice, support, because estates planning is something that's very new to a lot of practices, especially when you then aggregate that at a PCN level. So any practical guidance, tips, direction that you can point our PCNs and our practices towards would be really helpful. So Rachel, I'm going to come to you first of all.
Thanks, Caroline. So there's lots on various websites, and even the NHS England one has some good starting points around primary care premises, and just understanding the basics would be helpful. But looking to specialists who work in this space, I mean, the one thing I'm acutely aware of is primary care and general practice is super busy at the minute. It's not going to get any quieter. You're juggling all of these challenges and then trying to bring in a new workforce at the same time. So finding specialists who work in this space, who understand it, who have the time and the headspace to look at this properly, would be something I would encourage people to do. Obviously, the panel today can help with that, but there will be other advisors, property specialists out there. The other point, if I can sort of link it in slightly, which isn't answering this question, but does come back to another one, which is don't forget about our patients. And our patients may well have some of the answers. They may well know where there is a estate that could be used, or they may well have a view that actually that won't help us and we need something else instead. So again, though, that takes time. So can you bring people in who could help with some of the patient engagement? It's actually navigating all the different support pots that are out there. I know from working with CCGs, there are people who want to help sort this out. There are people and pots of cash available, well, not cash, pots of money and funding available. It's being able to navigate that. And the one thing that primary care doesn't have a lot of time a lot of at the minute is time to be able to navigate that. So if you can access the support from people like us who will do this for you to try and help, then please do.
Thanks, Rachel. Paul, we've had a specific question around in relation to designing a new building for primary care. What architectural guidance is there out there that PCNs can access? Is there a guidance document or a publication that PCNs should be looking at?
There are a series of documents that were produced by the Department of Health that were meant to be used as guides by both consultants as well as professionals operating within the primary care sector. Unfortunately, due to sort of funding issues, etc., that kind of lost its way a little bit, and those documents, although still heavily used by consultants because they are very good, I'm referring to the health building notes and sort of health technical memoranda, sort of ceased being updated. But the good news is that the powers that be have recognised the importance of those documents, and one of the organisations that I'm a member of, which is Architects for Health, have been sort of lobbying and pressuring government and in particular the Department of Health to get these documents up and running again, because we recognise the value of them and how much they could help PCNs and others within the sector move things forward. So the good news is that they are due to be republished, and that's just coming to the end of the process now, and so it's a case of watch this space, and that will be something that will be imminent. So within the next month or two, those documents will be available. But in the immediate term, obviously professionals such as ourselves, and there's a whole range of them, consultants, and kind of linking in with the previous question as well, going to an external source brings with it a kind of objectivity, which can be very helpful to PCNs. So when you're trying to navigate internal teams and look at certain aspects of what can and can't be done, it can be difficult to see the wood for the trees, as it were. So to bring a fresh pair of eyes in, and it doesn't need to be a professional at all. It might just be some, it might even be somebody from within the PCN, but from a different area of that PCN, comes into a different building and can see things that couldn't be seen by others because they're in amongst it all so much.
Mm.
Yeah, I think that's a really interesting point, Paul, and we've seen, different practice managers working together, across PCNs or across practices to share what works and what doesn't work. And I think sometimes if you're working in that environment every day, you become quite blinkered, and you miss some of potentially the opportunities that you could already take to maximise your buildings. And as Rachel says, link that back into your patients. So, Health Watcher are more than happy to come and do a walk of your practice with you and help to look at where the opportunities are. Think about how you could use that creatively where estates are concerned as well. Paul, I'm going to come to you in terms of where would you point a PCN to access support and guidance when it comes to estates planning?
Yeah. Well, as Paul said, the HBN 11 guidance is the key guidance for architects and surveyors, which really gives a lot of detail in relation to specification, design and refurbishment, including room sizes and so on. Is obviously not quite as straightforward as that in a lot of cases. And the RICS Working Party has, again, as Paul said, worked on a first draft, which is now out and ready for review, but will possibly be subject to a little bit further review to take into account COVID measures as well as PCN requirements, so quite timely fitting in together. But that will be available and is an ideal scenario. But I think what a lot of GP premises will feel like is that they are, they have all these requirements and these needs, but it's very, very difficult to put into place. And it's very easy for us to talk about guidance, and you need to do this and you need this amount of space and so on. But we all know from applying for, even applying for grant funding for extensions and so on, it's a lengthy process. there isn't a huge amount of support, I don't think, at the moment, and I think it's evolving. We're all learning together, NHS England, the CCGs, our property professionals, and the idea is that we would all like to work together to help you individually come up with a plan and a structure. There is no absolute answer, no huge amount of support at the moment. Ideally, we'd have NHS England with a specific estates person for these particular issues, which may well happen over a course of time. But I shall stop now because I know we're running out of time.
Thanks, Paula. And I think it's worth saying on that, we were in conversation with Tim Ballard of the CQC earlier on this year when we went into the first lockdown, and his view was that the CQC will not stand in the way of PCN development, especially when it comes to estates planning, because there is that query around how locations become registered, and that has felt like a barrier specifically in terms of working in community settings and how you can go about delivering services from a community setting. So I know that's on the CQC's agenda at the moment. Thank you to our panelists. It's a really meaty topic, and I think perhaps one that we'll revisit in the new year as and when evolving guidance comes out. We understand that CCG estates teams are going to be really pushed in the early parts of next year to start being a little bit more proactive in working with PCNs around their estates. So hopefully we might be able to link in on a future webinar and discuss that early next year. Thank you to our panelists for joining us. Thank you to everyone that's watched. Just a reminder that our next webinar is on the 2nd of December. A really exciting topic. We're talking around population health management for PCNs. What is population health management and how PCNs can start with a PHM approach. So please do register and join us for that. If you've got any questions for our panelists, then you can get in contact with us after today's webinar. You can email us at webinars@onemedicalgroup.co.uk. Thanks for your time and have a good day, everyone. Thanks, panel.
Thank you.
Bye.